Okay, so for chapter 4, we're going to go over the reproductive system concerns. We're going to go through some different menstrual disorders, talk about STDs and their treatment as well. So menstrual disorders, we're going to go through a few of these that I really want you guys to understand. You will be tested on the different types of menstrual disorders. Okay. So the first one is going to be amenorrhea. Okay. Amenorrhea is the absence of flow. It can occur for two different reasons. The primary reasons are going to be things like anatomic issues, endocrine issues such as type 1 diabetes, eating disorders, or medications. And secondary is going to be caused from pregnancy. Okay. Amenorrhea is concerning if we have an absence of flow and secondary sexual characteristics by age 13. Okay, so if we've noticed that she is going through puberty, but we don't have any menstrual flow. Absence of menses by age 15. Absence within 5 years of breast development, or 6 months or more cessation after having a period. Okay. When we're talking about these menstrual disorders, keep in mind that moderate obesity can cause early onset, okay, because we have higher levels of estrogen, and so we can actually have a period sooner with obesity, whereas malnutrition can create a delay. So people who are very healthy and active, maybe runners, okay, they're going to have a delay in a menstrual cycle. So when we're seeing if this amenorrhea is concerning to us, we have to take into consideration the patient's size and their activity level as well. Management of amenorrhea includes ensuring that patient is not pregnant. So then after we know they're not pregnant, we know that it's primary amenorrhea. And then we can do some counseling and education, such as correcting weight loss, decreasing their exercise routine, stopping medications that are not allowing us to have a menstrual cycle. Dysmenorrhea is going to be pain during or before menstruation. Again, this has primary and secondary. So primary dysmenorrhea is associated with ovulatory cycles. Okay. We have a rise or a release of prostaglandins, and those prostaglandins, remember that we talked about, they help that uterus to contract. Okay. It increases the amplitude and the frequency of those uterine contractions. That's going to cause a vasospasm. Okay. With primary, it has to occur with ovulatory cycles. Okay, so sometimes after a patient has had their first menstrual cycle, they won't have any ovulatory cycles for those first 6 to 12 cycles. After those cycles have been established, then they will begin to ovulate. Okay, so sometimes they're like, well, my menstrual cycle didn't hurt, the last 6 months, and then this month it does hurt. It's because they're now having ovulatory cycles. Okay. Primary dysmenorrhea occurs most commonly in teens and early 20s. Management is going to include heat to dilate and relax the muscles, aerobic exercises to decrease pain. We want them to decrease their sugar intake and salt intake 7 to 10 days before their menstrual cycle to reduce fluid retention. And we can also administer NSAIDs or possibly some oral contraceptives if the pain is that bad. Secondary dysmenorrhea is associated with some sort of pelvic pathology, such as having endometriosis or fibroids or pelvic inflammatory disease, PID. Okay. This develops later than primary dysmenorrhea does. It's usually after age 25. And management for secondary dysmenorrhea includes diagnosis and removing of that underlying pathology. So if they have endometriosis, we may need to have some surgical procedures to try to decrease that and remove any fibroids that are present that are causing that pain during menstruation. Menstrual disorders, some more of them, premenstrual syndrome or PMS. So this is going to be cyclic symptoms that occur in the luteal phase of the menstrual cycle. Okay. It's a very poorly understood condition that has physical and psychological symptoms, and they can affect the lifestyle or work. And then they have a symptom-free period, and then it occurs again. Okay. It's characterized by fluid retention, breast tenderness, behavioral changes, irritability and cravings, fatigue, and backache. The specific group of symptoms that we talked about, remember they occur in the luteal phase. And so after the menses onset, their symptoms are going to disappear, hence premenstrual. There is premenstrual dysphoric disorder, which is more severe, and it actually lasts 7 to 10 days of the menstrual cycle. Okay, don't focus on that one, look more at premenstrual syndrome. Know that neither of these can occur if there's not ovarian function. Okay, therefore we can't have premenstrual syndrome before puberty, during pregnancy, or after menopause. Management for premenstrual syndrome is going to include education, diet and exercise. We want them to limit their sugar and alcohol intake and avoid smoking. Medications that they could be prescribed include some diuretics, NSAIDs, progesterone. They could be on some oral contraceptives or also some antidepressants such as an SSRI. Endometriosis is going to be the presence and growth of endometrial tissue outside of the uterus. Okay. This can include tissue that implants on ovaries, the rectovaginal septum, the pelvic peritoneum, the cervix, so anywhere that's outside of that uterus. Some major symptoms that we'll see will be pelvic pain, dysmenorrhea, and dyspareunia, which is pain with sex. This is believed to be caused by retrograde menstruation. So the endometrial tissue is refluxed through the uterine tubes during the menstrual cycle and end up in the peritoneal cavity. When that happens, scarring can surround the tubes and prevent eggs from becoming fertilized. So sometimes with endometriosis, these patients become infertile and they have a hard time getting pregnant, and they have to look at other options to becoming pregnant. Management for endometriosis is going to include NSAIDs for pain. We want to administer some medications to suppress estrogen levels, and possibly surgical intervention if severe or incapacitating symptoms. So here's a picture of endometriosis. So as you can see, all those little blue spots are different places where it can implant. Okay, that endometrial tissue implants. So that's what causes the pain, is from the implantation on other organs within the body. Here's another list. These ones I'm not really going to test you over. I just want you to be aware of what these words mean so that if you are ever faced with having a patient with these, you kind of understand why. A lot of these are reasons why patients have hysterectomies. And so as you guys saw when you were in women's health, these patients had a reason for having a hysterectomy. Okay, it was probably an issue with bleeding. So oligomenorrhea is infrequent bleeding. We have hypomenorrhea, which is scanty but at a normal interval. Menorrhagia is excessive bleeding. We have metorrhagia, which occurs during periods, or I'm sorry, not during, between periods. We also have leiomyas, and these are just uterine fibroids, and they can cause them to have excessive bleeding. They have fibroids growing on their uterus. Okay. Abnormal uterine bleeding. This one I'm going to go into a little more depth on. I want you guys to understand abnormal uterine bleeding. It is from organic causes, such as systemic diseases, reproductive tract diseases, or hormones. So this is any form of bleeding that is irregular in amount, duration, or timing, and not related to regular menstrual bleeding. Okay, so this happens other times than during their menstrual cycle. The most effective treatment is going to include oral or IV estrogen. We may be doing a D&C if bleeding doesn't stop within 12 to 24 hours. We'll typically have these patients continue oral estrogen and progestin after the episode so that they don't have a reoccurrence. And if it continues, an ablation can be done where they go in there and actually cauterize some of those vessels that are bleeding. Dysfunctional uterine bleeding, there's an absence of organic causes. So this type of bleeding is usually caused by anovulation or insufficient progesterone that's going to cause that shedding. Okay, so it's not organic. We have some other issues going on. Sexually transmitted infections, or STIs. When assessing for this, we need to look at prevention strategies, educating on safer sex practices, reducing the number of partners, encouraging condom use or vaccinations to prevent STDs. The real term now is sexually transmitted infections, or STIs. I still call them STDs, but just know it's the same thing. When we are assessing, we can use the little mnemonic, the 5 Ps, to assess and see what their practices are. Okay, what is going on? Why is this patient at risk for an STD? Okay, so the 5 Ps include partners. We need to know the number of partners that the patient has had, their practices. We want to know what they're doing to try to prevent pregnancy, what kind of protection they're using to prevent an STI, and then also if they've had any past histories of an STI. So there are 3 reportable STIs. This includes chlamydia, gonorrhea, and syphilis. Okay. We're going to talk about each of these. The big things that I want you guys to get out of this is the signs that we see, and also fetal effects of STDs. Okay. There's a couple tables to review in your book. Table 4.3 on page 75, and also table 4.5 on page 86. And these discuss pregnancy and the fetal effects. Okay, so like I said, know what these can cause within the fetus if this patient does become pregnant with an STD. Okay. So the first one we're going to talk about is going to be chlamydia. This is the most frequently reported. Most cases are asymptomatic. So a lot of patients do not know that they have this. Therefore, it's silent and highly destructive. Some complications that can come along with this include salpingitis, or pelvic inflammatory disease. It increases the risk for an ectopic pregnancy, and also for acquiring an HIV infection. If symptoms are seen, we can see some spotting, some postcoital bleeding, or a purulent cervical discharge. Effects for the mother, if she does become pregnant, include premature rupture of membranes and preterm labor. And for the fetus, we can have low birth weight. We do screen all pregnant women because of the risk that it is asymptomatic. Treatment for chlamydia includes doxycycline or azithromycin. Gonorrhea is the oldest communicable disease in the United States. Again, it is often asymptomatic. If we do see symptoms, we can see a greenish yellow discharge, painful menses, or menstrual irregularities. Okay. If a patient is pregnant, they're at a higher risk for premature rupture of membranes, preterm birth, having chorio, so remember the infection within the amniotic sac, intrauterine growth restriction, and postpartum sepsis. Management for gonorrhea includes Rocephin, that's given IM, but we have to be aware that there are some drug-resistant strains that are increasing. Okay. The last one is syphilis. This can lead to a serious systemic disease that can actually lead to death if it's not treated. The primary and secondary, so with primary, we just have a primary lesion. Okay, it shows up 5 to 90 days after an infection. It's a shallow, non-tender, clean ulcer. Secondary infections appear 6 weeks to 6 months, and it's a widespread symmetric maculopapular rash. Okay. These patients can also experience some fever, headache, and malaise. This is tested during pregnancy as an RPR or VDRL. Okay, those are the two labs that test for syphilis. However, seroconversion occurs 6 to 8 weeks after exposure. So even if we test them one time, we're going to test them again in a couple months to ensure that we didn't miss it. Make sure that that seroconversion has occurred. Transplacental transmission may occur, which means that this baby could have syphilis. Maternal effects include a risk for miscarriage and preterm labor. And fetal effects include growth restriction, possibly the congenital infection, or stillbirth. Management for syphilis includes penicillin G and mandatory monthly follow-ups until their treatment is completed. So they have to go back multiple times to be treated for syphilis. So here's just a little picture as I talked about primary. You can see that they just have one lesion. And with secondary, we have multiple widespread lesions. The next thing is going to be pelvic inflammatory disease, or PID. So this is the ascending spread of microorganisms from the vagina and the endocervix to the upper genital tract. This most commonly involves the uterine tubes and the uterus. So this is going to cause salpingitis as well as endometriitis. It's going to increase our risk for an ectopic pregnancy, chronic pelvic pain, and infertility, okay, because it's going to cause scarring to those tubes and to the uterus. These patients may experience pain, fever, chills. They could have some increased vaginal discharge. Sometimes it is hard to diagnose because we do have such a large variety of vague symptoms, but we can specifically assess their temperature. We can note that they have abdominal tenderness, their elevated SED rate. So when we draw their labs, their SED rate, their CRP are going to be elevated as well. And then whenever we do labs on their vaginal discharge, we can also see that they possibly have gonorrhea or trichomonas. Management for pelvic inflammatory disease includes counseling on prevention. So we want to ensure that this patient does not have this again. We're going to treat with broad spectrum antibiotics. And for these patients, we want them in bed rest in semi-Fowler's position. This is to help promote drainage. Okay, so we want them sitting up a little bit and help drain any abnormal discharge from their uterus. We want to decrease the number of pelvic exams. We don't want to continue to introduce bacteria into that vagina. So decrease pelvic exams. And then we can administer analgesics for pain. Okay, the next thing is going to be human papillomavirus. This is also known as genital warts. It is the most common viral STI. Okay, there's approximately 100 different types of HPV, and several of these types can cause genital cancers. Some symptoms that may be seen include profuse irritating vaginal discharge, postcoital bleeding, and bumps on the vulva or labia. HPV has a long latency period. Therefore, the history of exposure is hard to determine. So someone can become infected and not know for months down the road. Okay, and by then they may have a different partner, and therefore it's hard to determine which partner they actually received it from. Management for HPV includes keeping the area clean and dry. We want them to wear cotton underwear and aid their immune system. Okay, we want to ensure that they stay healthy. The warts typically resolve on their own from their immune system strength. And then we also want to try to prevent the spread of HPV, and this includes abstinence, as well as vaccines such as Cervarix and Gardasil. Okay, these are given at a very young age, and there's a lot of controversy about administration of these medications that I'm not going to discuss in this class, but just be aware that these are offered very young, like up to or as early as age 12. We can start to see patients getting these vaccines. Okay, herpes. We're not going to talk a lot about this. You guys know that there's two different types of herpes. One is transmitted sexually, the other non-sexually. We can have recurrent ulcers that are painful. Also can see some fever and chills or malaise. There is an increase in miscarriage rates in the first trimester. Okay. And herpes can have some effect on the fetus that we're not going to really go through, but just know it can affect the fetus. Management for herpes, we don't have a known cure at this time. Treatment during infections include prevention, providing self-help and psychologic support. Herpes can be treated with acyclovir for type 1. And for type 2, it can be used as a suppressive therapy. So we're just trying to help them during those outbreaks. Okay. And we want to encourage them to keep the lesions clean to avoid any secondary infections. The next one is HIV. So this is severe depression of the cellular immune system that leads to acquired autoimmune deficiency syndrome. Okay, so whenever it continues to progress, we end up with AIDS. Okay. Seroconversion of HIV takes 6 to 12 weeks after it enters the body. We typically have a flu-like response, some fever, headache, nausea, and weight loss. The lab test can actually show up like leukopenia. Okay, we may have some thrombocytopenia, anemia, and an elevated SED rate. This can transmit from the mother to the fetus, so it is very important that they adhere to treatment to try to avoid any transmission to that fetus. We don't want to have an HIV positive fetus. We treat this with a triple drug antiretroviral prophylactic or highly active antiretroviral therapy, or also known as HART therapy, during the pregnancy. Okay. And before delivery, we actually draw a viral load, and based on their viral load, they may be able to deliver vaginally. If their viral load is too high, we're going to deliver by a cesarean section to prevent transmission. Okay. Some other infections that I just want to kind of briefly go over, we've talked about some before. The Zika virus, we know that this is spread through mosquitoes. Okay. And it can lead to microcephaly in the infant. Toxoplasmosis, the effects are typically absent in the mother, but it is related to the exposure of cats, being in gardens, or consuming raw meat. We can have stillbirth, microcephaly, hydrocephalus, and also blindness and deafness. And then the last one is the cytomegalovirus. Again, we have absent maternal effects. These patients can have babies that are stillborn and also have cerebral palsy or microcephaly. There is no treatment. It's more just about prevention. Some vaginal infections that we're going to talk about. So vaginitis in general is any abnormal vaginal discharge caused by a microorganism. So we're going to talk about some different microorganisms that cause these vaginal infections or cause vaginitis. So the first one is going to be bacterial vaginosis. So this is characterized by a fishy odor that is thin, white, or gray. Okay. This can lead to preterm labor, preterm rupture of membranes, and intra-amniotic infections such as choreo. It can also cause postpartum endometritis. Okay. To treat bacterial vaginosis, we administer Flagyl, okay, or intravaginal Flagyl as well. Okay. Candiditis, or also known as a yeast infection. This is the second most common vaginal infection in women. Specifically patients who are on antibiotic therapy, are diabetic, are obese or immunosuppressed, they're at a higher risk for developing a yeast infection. It is characterized by vulvar and vaginal pruritus, along with a thick, white, lumpy cottage cheese-like discharge. This can be treated with over-the-counter medications such as Monistat. We want them to seek treatment for their first infection, or if they're having infections occur frequently. Okay, we want to see if there's something that we can do, maybe some education, make sure that they're wearing appropriate clothing or performing pericare appropriately to try to prevent these future infections. Sitz baths can help to decrease irritation during a yeast infection. And we also want to encourage them to wear loose-fitting clothing. Trichomonas is another sexually transmitted infection that can be asymptomatic, but oftentimes they will experience a yellow to green malodorous discharge and have inflammation of the vulva, vagina, and irritation. Okay. We treat this with some nitroimdazoles. Okay. And this can have some effects on the baby. I didn't cover it here, so don't worry about it. But just know that each of these vaginal infections can have lasting effects on that fetus if they're not treated. And then the last vaginal infection that we are going to talk about, we have talked about it a few times during class, but I want to review it one more time with you guys, is going to be Group B streptococcus, or GBS. This is associated with poor pregnancy outcomes. They can have preterm birth or premature rupture of membranes. Remember that we do not screen for this until 35 to 37 weeks. And even though we screen for it at 35 to 37 weeks, we are not going to treat for it until immediately before delivery. Okay? GBS is a normal vaginal flora for any woman. However, it's an issue if it's transmitted to the fetus during delivery. Okay? So we don't want to screen them at 35 weeks and treat them then, okay, because it could reappear. We're going to treat immediately before delivery. Okay? And that's only if they're positive. If the patient is having a C-section, then we're not going to treat them because that baby is not passing through the vaginal canal where they would be exposed to the GBS. Okay. And we treat for GBS with penicillin G. Okay. It can also cause chorio infections as well. So we need to ensure that we're treating mom with some antibiotics. Okay. That is all that I have for chapter 4. Let me know if you guys have any questions when we have our Monday meeting.